Adverse Childhood Experiences by jbrabham, Monique Cohen and Heidi Romero. This presentation is intended for healthcare professionals in all lines of care, from nurses, to therapists, to practitioners. This presentation is to provide basic information of what adverse childhood experiences are and to introduce an understanding of how these experiences can contribute to disruptive behaviors found in other disorders. After completion of this technology project, the audience will be able to define ACEs, learn the cause of ACEs, discuss neurobiology, and discuss screening options and treatments. Let's test your knowledge. Here is a pre-test on ACEs. What are adverse childhood experiences, or ACEs? ACEs are defined as events that can be considered traumatic occurring in a child's life between the ages 0 to 17 years. These events can include actions against a child like violence, abuse, and neglect. Other environmental exposures may include parental drug use, household dysfunction, socioeconomic adversity, interpersonal loss such as parental separation, incarceration, domestic violence, or other mental health issues in the home. These events are preventable, and if they occur, they can compromise the person's health and wellness. ACEs may be responsible for alterations in the child's brain development, resulting in substance use and abuse, mental health, and chronic health illnesses later in life. ACEs have been associated with increased risk for anxiety disorders, depression, and suicide. The prevalence of ACEs is astonishing. 1 in 6 adults have experienced 4 or more types of ACEs in their life, and 61% of adults had at least one ACE. ACEs are more common across low, middle, and high-income countries. People with 4 or more ACEs have greater odds of developing anxiety and depression. Approximately 30% of all mental disorders are attributable to ACEs, including 30% of patients with anxiety, 40% of patients with depression, and 67% of lifetime suicide attempts. Clinical features often observed in children as early behavioral problems, low academic achievement in school, and relationship problems with peers and parents. Children exposed to ACEs may partake in risky behaviors, especially boys. Children exposed to ACEs by the age of 5 were associated with poorer socio-emotional functioning such as attention problems, social problems, and aggression. Children who are maltreated can be observed as having a difficult temperament, anxiety, and being withdrawn. Patients exposed to ACEs showed volume reduction of the hippocampus as compared to patients that were not exposed. In men exposed to ACEs, there was a greater hippocampus reduction than women. This may be due to the protective effect of estrogen. Children that were brought up in an institute or by a chronically depressed mother showed increased amygdala volume. But in adults with a diagnosis of borderline personality disorder, dissociative identity disorder, and substance abuse, there is a reduction of the amygdala after exposure to an ACE. The larger size of the amygdala may be associated with emotional or physical neglect early in life, and the smaller volume can be related to those with a psychopathology and exposure to abuse. A child with known exposure to domestic violence demonstrated a change in the inferior longitudinal fasciculus as well as reduced visual cortex and right lingual gyrus gray matter volume. People exposed to childhood sexual abuse showed thinning of the somatosensory genital field. This thinning affects self-awareness and self-evaluation. There are many risk factors associated with ACEs. I will list a few. Children who do not have a close relationship with their parents are at risk. Early onset of age with sexual activity or dating. Children that engage in aggressive behavior or delinquent behavior are at risk. Living in a single-parent home or low-income household. Spanking or corporal punishment can lead to the child developing an ACE. Events leading to ACEs can be found in those living in areas high in crime, high violence, or poverty. Children that have easy access to drugs and alcohol. Children that have a parent incarcerated or experience parental divorce or separation. These are just a few risk factors associated with developing an ACE. Screening assessments are not always reliable due to lack of parental or caregiver cooperation. They fear the answers they provide may lead to being judged or reported to Child Protective Services. The Whole Child Assessment is a self-reported tool designed to be an interview guide to be used at pediatric well child visits. This assessment tool offers age-specific versions and is available in English and Spanish. It is designed for children ages 0 to 20 years. Each version incorporates questions about exposure to and risk of ACEs as well as other social determinants, safety, substance use, mental health, relationships, sleep, physical activity, nutrition, dental care, tuberculosis risk, and interval history. The use of the Whole Child Assessment during well child visits facilitates time prioritization to help identify and address factors most important to health outcomes. The Pediatric ACEs and Related Life Events Screener, also known as PEARL, screens for a child's exposure to ACEs and other potential risk factors. Factors that may increase a child's risk for negative health outcomes include toxic stress such as bullying, community violence, and food and housing insecurity. The PEARLs is divided into 2 sections. The first section screens for abuse, neglect, and dysfunction in the household. Section 2 screens for home hardships such as food insecurity, housing instability, and other significant life events such as caregivers' serious physical illness or death, community violence, bullying, and discrimination. There is no formal diagnostic criteria for development of an ACE, as not everyone develops an ACE to an experience. Each person reacts differently to a traumatic life events, and that reaction is the foundation of an ACE. Only a licensed mental health practitioner can diagnose a mental illness, but any health professional can determine exposure to an ACE, which can lead to a mental health disorder. Adverse childhood experiences are associated with more complex and severe prognosis of many mental illnesses. In substance use disorder, severe sexual and physical abuse are substantially associated with the use of heroin. Severe physical abuse alone presents with a link to cocaine use. Schizophrenia demonstrates a causal relationship with ACEs, with a proportional rise of severity of schizophrenia based on the severity of ACEs. Furthermore, ACEs demonstrate poorer recovery from schizophrenia. Major depressive disorder is at higher risk of development if ACEs occurred, and if sexual and physical abuse occurred, the individual is more likely to experience higher levels of depression. Bipolar disorder and ACEs are likewise associated with higher prevalence. Hospitalizations, resilience, and response to treatment are all poorer in those with both ACEs and bipolar disorder. Obsessive-compulsive disorder with preceding ACEs demonstrates a more intense and frequent presentation than that of those without ACEs. ACEs increase the possibility of severe mental illness, higher rates of suicide, and poor response to treatment in individuals with obsessive-compulsive disorder. There is no specific pharmacological treatment for ACEs. The most significant treatment is early detection, intervention, and prevention. Family support groups are important to promote positive parenting and home stability, which will in turn reduce home environment ACE development. Implementing national programs focusing on teacher, police, healthcare worker education to aid in early detection will benefit those at risk by raising awareness. Primary prevention is the most effective treatment. Eisman et al. Conducted a research study in 11 pediatric primary care offices with 1,300 participating families over a 3-year period. The interventions included screening for psychosocial concerns, parental coaching and teaching, assessing for positive parenting, and primary prevention program by pediatricians and parenting specialists. After 3 years, the mothers showed significant improvement in their role satisfaction, parenting efficacy, and parent-child interactions. Parents appreciated experience normalization, non-judgmental support, strategy implementation, and parental empowerment. The learning theory selected for delivery of this educational content is the information processing theory. This theory consists of 5 key steps. The first step is known as the attention step, which involves display of attention-getting media, such as a PowerPoint presentation. The second step, the sensory step, involves engaging the senses, such as the audio and visual engagement of this presentation. The third step, working memory, is done by organizing information in easy-to-retain pieces of information, such as the information on these slides. The fourth step is information processing, can be aided by recall and review of information, such as the post-test of this presentation. The retrieval stage is the final portion of this theory and the most important, as it will be the one necessary to utilize in order to have an impact on the clinical practice of participants observing this presentation. Now, after learning what ACEs are, here is the post-test. Good luck. Thank you for watching our presentation.